On July 4, 2025, the One Big Beautiful Bill Act was signed into law. It executed the largest single reduction to social safety net spending in United States history. Legislators extracted nearly $1 trillion from Medicaid and the Supplemental Nutrition Assistance Program to offset sweeping new tax cuts. The public debate centered almost exclusively on those tax cuts. Meanwhile, the legislation quietly rewired the economics of the American healthcare system. The Congressional Budget Office projects 16 million people will drop off health insurance over the next decade. Simultaneously, private healthcare mergers and acquisitions, which peaked at $29 billion in late 2025, collapsed to $11 billion by mid-2026. The synchronization of these metrics indicates that federal budget reconciliation is now a primary variable in private healthcare asset valuation. Federal policy operates as a rigid set of systemic inputs that dictate downstream capital flows. When the federal liquidity pipeline constricts, it forces immediate, localized bottlenecks at the state level. These blockages don't eliminate care costs. They spill over onto the balance sheets of local clinical providers, transforming insured patients into an uncompensated care liability. The legislation utilizes specific funding mechanisms to intentionally shift systemic financial risk directly onto the operating margins of local providers. We can quantify this shift using data from the RAND Corporation, which projects the removal of $665 billion from state Medicaid funds by 2034. The cuts target specific financing levers historically used by states to maximize their federal matching dollars, namely state-directed payments and provider taxes. This map shows the projected percentage loss of Medicaid funds by state. Expansion states heavily reliant on those exact mechanisms, like Arizona, Iowa, and Nevada, face severe reductions exceeding 15% of their total Medicaid budgets. In nominal dollars, the largest dependent states absorb massive liquidity drains. California stands to lose $112 billion, while New York loses $63 billion. By contrast, non-expansion states that do not utilize these financing tools see almost zero impact. Florida, for example, absorbs a budgetary hit of less than 0.5%. The federal government is effectively shielding certain state mechanisms while penalizing others based purely on their Medicaid financing structures. Rather than a uniform federal pullback, the legislation engineers the selective draining of liquidity from specific regional healthcare markets. On the individual enrollee level, the primary cost-cutting tool deployed is a mandatory 80-hour-per-month work and community service documentation requirement. The stated intent of this rule is to generate savings by pushing able-bodied enrollees off of Medicaid and into employer-sponsored insurance. Empirical data published in the Georgetown Medical Review disproves that theory. The majority of Medicaid enrollees either already work low-wage jobs that do not provide health benefits, or they qualify for exemptions due to disability or caretaking responsibilities. This flowchart illustrates the actual mechanism of attrition. Bureaucratic hurdles like internet access, low literacy, and shifting work schedules act as physical filters, stripping coverage away from working people who simply miss documentation deadlines. When Arkansas and Georgia implemented similar requirements, complex documentation rules resulted in a 12% drop in enrollment within just 3 months. It had zero impact on actual employment status. Applied on a national scale, this mechanism drives the RAND projection of 7.6 million fewer Medicaid enrollees by 2034. The policy leverages complex administrative friction to bump eligible individuals off coverage. It generates federal savings through weaponized procedural attrition. Losing insurance coverage does not eliminate a patient's illness. It simply reclassifies them on a hospital ledger from an insured asset to an uncompensated care liability. This creates acute exposure for long-term services and supports, a sector where Medicaid operates as the largest single payer. The financial stress concentrates immediately on the clinical sites most exposed to these funding shifts, rural hospitals and nursing facilities. Look at these balance sheets. As the Medicaid reimbursement revenue pipeline shrinks, long-term care facilities are forced into immediate layoffs and service reductions for the elderly and disabled. The rural hospital sector faces an even steeper cliff. Approximately half of these facilities already operate on negative margins. Compared to their urban, commercially insured counterparts, rural providers rely disproportionately on Medicaid to survive. The sudden spike in uncompensated care pushes total margins firmly into the red. The massive federal savings touted by the legislation are directly subsidized by destroying the operating margins of rural and long-term care facilities. Institutional investors recognize this engineered structural fragility. This brings us back to the PwC data. Deal value for health services mergers and acquisitions dropped from $29 billion in late 2025 down to just $11 billion by the second quarter of 2026. This freeze is not driven by a lack of capital. Buyers possess record amounts of dry powder, but they are actively rejecting assets exposed to Medicaid policy volatility or uncompensated care risks. The valuation reality shifted. Investors have adjusted their models, demanding proof of reimbursement stability before deploying capital. Private equity firms have priced the legislation's systemic risk into their acquisition models, bringing the broader healthcare transaction market to a standstill. The valuation premium for healthcare assets shifted away from top-line patient growth and toward absolute margin defense. This triggered a surge in demand for verifiable hard-dollar revenue cycle management technologies. Investors no longer accept pilot-stage artificial intelligence as a driver for valuation. Capital is currently flowing toward AI tools with empirical proof of ROI, specifically documentation systems that code for complex care to guarantee higher reimbursements. The downward transfer of risk forced private capital to adjust its pricing for the operations that sustain American healthcare.